All right, thank you everyone for joining us today. My name is Carolyn Ingram. I'm the Health Plan President of Molina Healthcare in New Mexico. But one of the things I get to do in working at Molina is work nationally also, and really excited today to bring this panel to you. I lead our Molina Healthcare Charitable Foundation across the country. I'm the executive director of that organization. We have 21 state chapters across the country that work on bringing access to care, delivery to healthcare, and really trying to solve problems at the local level through a program we call the Molina Cares Accord. In New Mexico, the Molina Cares Accord has already made a contribution and commitment of over $400,000 to look at issues around access to care, especially in this topic of mental health and behavioral health that we're going to talk about today. And so I'm really excited to be able to host the panel today on behalf of the foundation, on behalf of Molina Cares Accord, and bring to you today all of these guests and speakers that are going to be presenting. As many of you know, May is Mental Health Month, and so it's a really great time to highlight this topic here in our state. A lot of us deal with this issue every single day in terms of whether it's members that we serve, whether it's family that we're trying to help or take care of, or even a friend. And we all know firsthand really the experience that we've had in the state of not having enough access to care. So I'm really excited to bring today's panel together as we start to talk about a deeper dive into this issue and how we can solve some of these problems and look at some of the opportunities that are out there. Before we get started with the panel, I want to make sure and introduce our keynote speaker for today. It's really my pleasure to introduce the Acting HSD Secretary, Carrie Armijo. She has over 2 decades of working on helping individuals and caring for individuals in programs through her experience at HSD. She started out working in the Cabinet Secretary's office back in June of 2000 and has held several different roles inside the department, including acting as Medicaid director, deputy director, working across the medical assistance program, and helping to lead the Affordable Care Act. I had the pleasure of getting to work with Carrie back when I was Medicaid director for about 8 years, and I can tell you she knows firsthand exactly what it is to get these programs up and running. She has put in her dedication and her time really into serving the state. So I'm really excited to have her here today presenting as our keynote speaker. So Carrie, let me go ahead and turn it over to you.
Thank you so much, Carolyn, and thank you, everyone, most of all for inviting me to join you for this really interesting conversation today. I'm really happy to be here to talk about what the Human Services Department is doing to address behavioral health capacity and to improve access to behavioral health care here in New Mexico, and what we're doing together in partnership with all of you to improve the healthcare of New Mexicans in our state. So moving to, I guess I have slides that are not up, so I just wanted to, thank you. So we can go to the second slide, please. Okay, so I think, most of you are familiar with the Human Services Department here in New Mexico, but we always set the context by talking about our mission, which is really to transform lives. We work with our partners, that includes all of you on this virtual meeting today, to design and deliver innovative, high-quality health and human services that improve the security and promote independence for New Mexicans and their communities. And I really just want to call your attention to goal number 1, which is what I'm the most passionate about, which is helping New Mexicans and really making sure that we are focused on improving the value and range of services we provide to make sure that every qualified New Mexican receives timely and accurate benefits, and that includes access to behavioral health and Medicaid. Next slide, please. Okay, so we always start by just doing a really simple land acknowledgement because we are so fortunate and grateful to reside here in this beautiful state of New Mexico. And so on behalf of all of our colleagues at the Human Services Department, we just want to acknowledge that we are on the unceded ancestral lands of the original peoples of the Apache, Dene, and Pueblo, past, present, and future. And with gratitude, we pay our respects to the land, the people, and the communities that contribute to what today is known as the state of New Mexico. And every day, I am extremely grateful to live in this beautiful place and wonder at its natural beauty and cultural heritage. So before I start, I really just want to say thank you. I want to say thank you in particular to all the health plans, providers, thought leaders, and innovators who are part of this virtual meeting today for being part of the solution to what is a complicated problem. And so I just also want to say thank you for partnering with the Human Services Department. None of the work that I'm going to talk about today would really be possible at all if it weren't for all of you. So I just want to say thank you and acknowledge you right off the bat this morning. Okay, so many of you have probably seen this slide, but I just wanted to focus on the population and the customers that are served by the Human Services Department here in New Mexico. We actually have the highest Medicaid percentage by population total of any state here in the country. And we have about 1,080,708 customers as of April 2023, and that's 51% of New Mexicans. You can see that there are multiple counties here in New Mexico where we are serving more than 2/3 of the population through Medicaid. We have almost 1 million people enrolled in Medicaid, and we're going to talk a little bit about the unwinding of Medicaid as a result of the COVID-19 at the end of the public health emergency and what's coming up with that. But I also just wanted to highlight that over the past 12 months, we served 212,575 New Mexico adults through behavioral health services here in our state. That includes across agencies as well as Medicaid. Okay. So I wanted to talk about our focus on rebuilding the behavioral health network here in New Mexico. We have been very, very rigorously focused on this since 2019 under the administration of Governor Michelle Lujan Grisham, really focused on rebuilding and expanding the behavioral health network. So what we have done is really developed a guide to becoming a behavioral health provider, and we have reinforced our provider support teams here at the Human Services Department. And back in 2019, we increased behavioral health provider rates to 90% of Medicare, the reimbursement rate, and that was previously at about 70%. We're going to get ready to do some additional provider rate increases, which I'll talk about later. But those initiatives that we did have really resulted in a 104% increase in providers, behavioral health providers that are participating in the Medicaid program over the past 5 years. So it's a huge accomplishment I wanted to call out. We have a lot of work to do still, but I think all of those initiatives and really focusing on making sure that providers are paid adequately, and that we're working on helping them and providing technical assistance have really resulted in double the number of providers available to our Medicaid patients here in the state. In the past year, New Mexico has already paid more in Medicaid behavioral health than any of our contiguous neighbor states, which is great news. It means that we think we'll be able to attract more providers to our state compared to our neighbors. And looking ahead, we're really focused on simplifying credentialing and enrollment processes to make those simpler. We hear a lot of feedback from behavioral health providers that we need to do work in that area. So we're really focused on removing all administrative barriers and making it as easy as possible for our providers to participate in the Medicaid program. So I'm just going to talk briefly about a few initiatives that are on the horizon. And one of them is the aggressive pursuit here in New Mexico of new opportunities to implement certified community behavioral health clinics. There's a new reimbursement methodology that we think offers a much more solid financial footing for agencies that are willing to do the work to become these types of providers. And what they really do, what they will really offer to New Mexicans is more rapid access to care, higher quality services, better coordination and integration of care, and more robust crisis response. And so we're really, really excited. We're in the planning phase. There was some additional funding that was appropriated to HSD for this effort. And so you'll be hearing more about this as a really focused strategy for the agency over the coming months as we start to roll this out. I just wanted to talk briefly about 988. We've had a 100% increase in the number of 988 crisis calls, chats, and texts. And the interesting thing here is that we're seeing a big increase in the number of patients who are really seeking help with a wider array of crises than the prior suicide line. So you can see, almost 20,000 total contacts, and about 7,200 of those were for suicide related issues. So, we're really connecting with people over a broader set of issues for crisis, which is good news. And we're able to dispatch support based on the assessed needs of the callers. So HSD is very focused on training and credentialing certified peer support workers as part of the crisis response strategy. And we currently have more than 600 peer support workers who are serving as critical first level responders in crisis triage centers and mobile crisis teams. So we're really focused on that crisis response, particularly how we roll that out in rural New Mexico. And then I wanted to just mention another innovation that we've been emphasizing here in New Mexico, which is the treat first model. This approach prioritizes direct care and treatment first, instead of emphasizing gathering of data and assessment first before we see patients. We're really allowing providers to gain that assessment information over multiple visits. And so this is resulting in some interesting things that I wanted to highlight. We are noticing that more than a third of patients have had their needs resolved within 4 visits. And this has had a substantial impact on the no-show rate for appointments, because it focuses on the therapeutic relationship rather than a series of, frankly, bureaucratic data gathering activities. And so we've seen that we have less than a 10% no-show rate compared to 40 to 60% in sites without treat first. So a lot of positive feedback from patients, but we just wanted to highlight the results from that initiative. Okay, a couple of other things to highlight quickly before I turn it back over. We did have a few really big initiatives that passed through partnership with the governor and the legislature this past legislative session. One of the things I wanted to mention is Senate Bill 7, which creates the Rural Healthcare Fund. So that bill, we ended up with, the bill passed, and we ended up with an $80 million appropriation to the Human Services Department. The design of that is really to provide startup grant funding for new or expanded services in rural New Mexico counties. And a very big highlight of that is going to be in the behavioral health arena and really helping providers stand up new services in rural areas to make sure that we're meeting the needs of those communities. So a couple of timelines I wanted to mention. HSD is going to be requesting letters of interest from providers in June, so we can get a sense of what kind of interest is out there and how much money providers need to start really thinking about, these startup services. And then we're going to be opening up the grant application for this program, at least for the first round of funding, in September. So we will open that up from September to October and hopefully receive a robust response from our providers who have really been asking for this kind of support for years. And the first round of funds will be issued for calendar year 2024 to start in January. So we'll be hopefully really actively building services from the ground up starting in January and allowing providers to expand. And then a couple of other things I just wanted to highlight from House Bill 2, which is the budget bill for those of you who aren't familiar with the language that we use. There is an unprecedented investment in provider rates through Medicaid in House Bill 2. So we're really looking at an increased rate, overall rate increases totaling about $350 million to the provider network here in New Mexico, which is really, really exciting. And those will start to go in place July 1st. For behavioral health, we are doing rate increases to 120% of Medicare. So I cited that number 90, we're at about 90% of Medicare now. So we're going to do some big increases for the behavioral health network up to 120%. There's funding for comprehensive behavioral health residential crisis management and transition services in the bill. We have funding for startup and expansion of CCBHCs, which I talked about earlier. There's funding for housing assistance for people affected by opioid use disorder. expansion of the SBIRT, which I think probably many of you are familiar with, and expansion of telehealth services for people who are affected by opioid use disorder. So lots of exciting initiatives called out, lots of legislative, and of course, a lot of interest from the governor's office in supporting behavioral health here in New Mexico. Another thing I just wanted to call out, which is a very substantial bill that passed, was Senate Bill 16, and that is the creation of the Healthcare Authority Department. And that really takes the Human Services Department and changes it to the Healthcare Authority Department as a single unified department that will be responsible for healthcare purchasing and policy setting. And the goal of this is really to use Medicaid as the foundation for improving health service delivery and outcomes for all New Mexicans. And a critical part of that is going to be behavioral health, and how can we leverage the work we're doing today and take those improvements and make them bigger for New Mexico. And Medicaid is really going to be the foundation for that. You can see that we've had some really great data showing that our health plans in Medicaid really have been successful at increasing the number of visits with both behavioral health providers and non-behavioral health providers for behavioral health diagnoses. And that's going to be the foundation by which we improve services for all of New Mexico. And Carolyn, I promise I just have one more slide, okay? One more. Okay, thanks. I wanted to just call out, and I promise stop talking in just a second, I'm overdue. It is time to renew New Mexico. We have a huge healthcare event happening in our state with the unwinding of the COVID-19 public health emergency, and that means that we have to conduct a full renewal on our entire almost 1 million people who are on Medicaid over the next 12 months. We started that process in March, and people started to lose coverage in May. And so there are just 3 things I wanted to highlight here. We're really focused on people updating their contact information. Everyone's going to receive their renewal paperwork in a turquoise envelope, and we need them to complete their renewals. So to the extent that we can partner with you, we really want to do that. And that's why I put this shameless plug on here. We have a Renew New Mexico Partner Toolkit, which you can go to online, and we have social media on there. So anyone who wants to go on can really help us get the word out, and we would be extremely grateful for the partnership and your help in reaching our Medicaid customers and helping them retain coverage. So thank you, Carolyn, and I'll stop talking now. Back over to you. Thanks.
Thank you so much, Carrie. That was excellent, and it was really important to put in the redetermination slide and the information there. So no worries about that. I think we want to make sure we get the word out to everyone about the work that they need to do, and anything we can always do to help, from the foundation's perspective is a good idea. And I loved your presentation in terms of spelling out all of the different initiatives. You guys have your hands majorly full. We're super excited across the state to see the implementation around the provider rate increases as well. And so anything we all can do, I think, helping you is what we want to try to do. That's going to be a great start to tackling the issue today that we're going to talk about. So I want to go ahead and turn things over and the discussion over to Dr. Darcy Roban Marquez. She's the medical director and chief medical officer for Molina Healthcare of New Mexico. She helped us set up the panel today. So Dr. Roban Marquez, I'll let you go ahead and take it away.
Thank you, Carolyn, and thank you, Acting Secretary Carrie Armijo, for your remarks today. In my role as Chief Medical Officer of Molina Healthcare of New Mexico, and from my over 20 years of experience as a practicing physician and healthcare executive, I know firsthand the challenges our healthcare system is facing amid a growing shortage of workers. However, as a lifelong New Mexican, I also have seen this issue take shape and impact friends, neighbors, and loved ones coping with mental health disorders and crises. New Mexicans continue to face challenges in accessing quality care, and unfortunately, these disparities too often result in negative health outcomes due to delayed treatments or lack of treatment altogether. When you look at the data, New Mexicans report a higher level of anxiety or depressive disorders than the national average. With the known correlation between mental health and substance use disorders, some New Mexicans likely have behavioral health comorbidities that require care or attention across the care continuum. However, there are simply not enough providers to meet the rising demand in behavioral health services. Currently, New Mexico needs nearly 10,000 healthcare workers to bring the state up to national standards. As Secretary Armijo mentioned, this gap is especially pronounced in the Medicaid population, where there are approximately 2,700 licensed behavioral health providers who serve more than 670,000 Medicaid managed care enrollees. Unfortunately, this has resulted in roughly half of adults with mental illness in New Mexico not receiving treatment. With that background, I'd like to introduce Pat Davis, who will be moderating today's panel. Pat is the president of the Albuquerque City Council and the owner of 4 local Albuquerque area newspapers. Councilor Davis began his public service career as a police officer with the U.S. Capitol Police in Washington, D.C., and graduated from the FBI National Academy. He later earned a master's degree in criminal justice from New Mexico State University, Go Aggies, and worked on drug policy reform. He served as City Council President during the COVID pandemic and during the creation of the city's lauded Community Safety Department, a non-police response agency to address issues of addiction, homelessness, and behavioral health needs. Thanks for joining us today, Pat.
Thanks, Darcy. Thanks, Doctor. I appreciate it. And thanks so much to everybody for joining us. I see some names I recognize and a whole bunch of new folks as well. So we appreciate it very much. This is an incredibly important conversation, as we know, not just for our city, but for the state at large. And so I'm really honored and I appreciate the opportunity to join you all today to do this. To get us started, let me introduce you to our panelists who are going to give us a little more information and follow along where we've come from. Terry Randolph is the Chief Program Officer for Pix Health, a healthcare technology company that's focused on supporting individuals dealing with loneliness. She brings 30 years of behavioral health experience, providing a therapeutic intervention to all age groups in a wide variety of settings. Terry also has 18 years of experience working at executive level management with healthcare systems. Terry, welcome, and we're happy to see you.
Thank you.
Great. Jennifer Snyder, who I see here on my screen now, thanks for joining us. She's a psychiatric mental health nurse practitioner and clinician educator and assistant professor at the University of New Mexico, go Lobos too, at the College of Nursing. She has more than 15 years of experience as a psychiatric mental health nurse practitioner, a mental health counselor, and a pediatric nurse focused on working with children and their families. Jennifer, thanks for being here.
Thanks for having me.
Last but certainly not least, Paul Tucker. He's the CEO and founder of Turning Point Recovery Center and Focused Recovery of New Mexico. He's been a leader in behavioral health since 1996 while building what has become one of New Mexico's few private substance abuse treatment centers. Mr. Tucker, I'm really excited you're here, actually. I'm a fan of your work, so thank you so much for being here. So we'll do that. We'll get back to Paul as soon as he joins us, but that's okay because we are going to get started with the panelists that are here for us. For those of you that are joining us this morning or in the afternoon, if at any point during our discussion you have a question, throw it into the chat, throw it into everyone. We're watching those and we'll do our best to try to tackle those. But in case you have a great question and we don't get to it during our panel, don't worry. We've set aside a little time at the end to bring some Q&A back to our panelists. And I see Mr. Tucker's joining us now. So Paul, good to see you and thanks for joining us.
Glad to be here.
Great. We'll let some of our panelists retire their screens if they'd like. But in the meantime, I'm going to start and ask Terry to help us with this, maybe get us started. Actually, we were going to talk about this morning, and then I heard the Surgeon General on NPR this morning, actually, having this conversation. Terry, the U.S. Surgeon General recently announced that widespread loneliness in the U.S. poses a big health risk, possibly as big as smoking. There is a lot of evidence and increasing evidence that Americans have become less engaged with each other. I think we all know that before and certainly through COVID, and now even felt increased levels of loneliness due to COVID and the coronavirus pandemic, increasing the risk of premature death by, I think I've heard a number as much as nearly 30% in some cases. And even some with poor social relationships certainly have a greater risk of stroke and heart illness, and isolation is elevating people's likelihood, certainly for experiencing depression, anxiety, and dementia. So Terry, let's jump in here. Like beyond receiving treatment for from a mental health professional, what are some ways we can help those who are dealing with this unprecedented effects of loneliness, and why are we seeing this so prominently now?
I think, thank you for the question. And I'm really thrilled to see that the U.S. Surgeon General is really taking a good look at this. I think first and foremost, it's incredibly important that we begin to understand that loneliness is a chronic condition, and that can alter brain functioning and have really significant negative physical and mental health impacts, as you stated above. And this type of chronic condition really requires intentional and consistent interventions over time. It really is not something you can just have a 10-minute phone call. It's something that you really need to, that the health profession really needs to look at and get access to people with intentional and focused interventions for specifically loneliness. I think it's really important that we begin to acknowledge that it comes from a place of feeling disconnected and not really having meaningful connections in your life. It's perceived social isolation, and it occurs regardless of how many people you have around you. I think sometimes we have this idea that loneliness is somebody who is by themselves, which isn't true. It can be people who seem to have a lot of people in their lives, but they're not really feeling connected to those people, which again, I think COVID and post-pandemic really has been highlighted. I think, again, if you're talking with somebody or dealing with somebody who is lonely, I think it's really important for all of us to begin really destigmatizing this idea that loneliness is just a feeling. I think that most of us, almost all of us, will deal with loneliness at any given period in our lifetime. And we need to really help them connect and help them understand that they need to have access, and we need to provide them access to these intentional, focused interventions that we know really combat those negative brain functionings that occur with chronic loneliness, and really help them to address loneliness, which will again increase and help their physical and mental wellness in general.
That's great. Thank you so much. And I think that's important. Let's jump into really quickly and talk to some of the practitioners as well. Jennifer, if you're still with us, can you turn your video back on and join us? Let me ask, so you've got firsthand experience, so do all your colleagues at the College of Nursing. UNM and the state is investing big in increasing our nursing workforce. There's a huge new building going up right now. I know the governor and legislators helped to break that last year. I think that one opens next year, if everything stayed on track. But with UNM's a shortage of healthcare providers, including nurses, especially for vulnerable populations like those served by Medicaid and Medicare, access to healthcare continues to be a major issue. I mean, we know that rural access in particular has become a bigger challenge in New Mexico than in many other states. And so, Dr., how is the College of Nursing equipping future health providers with the tools they need to help serve mental health needs of the state? Is the school encouraging participants to remain in the state after graduation? We've always heard that our best and brightest go other places, but what's the strategy here, Doctor?
Well, thank you so much for the question, and I'm always happy to tout the work of the College of Nursing. First of all, serving vulnerable populations is really built into the mission of the graduate programs in the College of Nursing. In the last couple of cohorts, we've had 87% of students who complete clinical rotations in either rural areas or in health professional shortage areas. And I am the coordinator of the psychiatric mental health nurse practitioner program at the College of Nursing. And so I'm training students that specialize in psychiatric care, assessment, psychiatric medication, prescriptions and management, and then also psychotherapy. And we are really training students to treat patients across the spectrums of behavioral health diagnoses and substance use disorders. Our program's pretty small. We just had 9 graduates about a week ago, but we are growing. And I think that one of the things I'd like to highlight is that we really fill an important gap of helping to provide more mental health providers that can do psychiatric medication management and psychiatric prescriptions. And then on top of that, some of my colleagues in the primary care specialties of the nurse practitioner program have developed a new course in mental health care that they're providing to all of their graduate students in the primary care specialties because we know so much of psychiatric care occurs in primary care, and we want to better prepare students for that. And then your very important question about staying in New Mexico, about our most recent figures are that 89% of our recent graduates stay in New Mexico after graduation. And I really think a big piece of this is because a lot of our students are from New Mexico, certainly the majority. And another benefit that we have is because our students are completing clinical rotations in the state, almost all of my students, for example, are offered their first position as nurse practitioners from one of those clinical placements. I always tell clinical sites it's the best job interview you can have to have students with you for an entire rotation. And so that seems to really help keep people local as well.
Wow, 89% of your graduates are staying in New Mexico. I don't think that's the narrative that we're hearing, but I think that says a lot about what we're doing to invest in our healthcare future. So congratulations, and I hope that helps us to turn that corner. Before we get to questions, let me jump in and ask Paul to join us really quickly, because the other side of this is maybe not in the actual college or the clinical programs, but in these outpatient programs and substance abuse programs like Paul's. So let me jump in and say, and I'm sorry, I lost my notes right here, but we're back. That's great. So Paul, tell us a little bit, like, what is it that is happening with behavioral health disorders like anxiety and depression? Those are all closely related to substance abuse, either as self-medicating or coexisting conditions. What do we know that New Mexico has the highest alcohol-related deaths in the country? What do you see as the biggest obstacles for people trying to get into treatment in New Mexico?
Well, there's a lot of stuff going on there. Some of it's the context. What do people need? What's going on in their world? Are they ready for treatment? Do they want to go into treatment? Are they resistant? Something going on with them, maybe struggling with wanting to do it. But then there's if they want to do it, what are the barriers to doing it? So the barriers, can they pick up the phone? Can they talk to somebody right away that's knowledgeable, or do they get a voice machine? And do they get a system where they end up having to wait, or can they get in right away? So, we're always working on improving things in terms of trying to get answer the phone when they call, talk to somebody that can help them, that's empathetic, understanding, non-judgmental, and help them work through some of the barriers that they're working on their end, because they've got these things going on where they're worried about, well, if I go to treatment, who's going to take care of my kids? Am I going to have a job when I get back? But what are people going to think? There's all these kind of things going on with them. And so it's really important that when they do pick up the phone, because, there's all these things, like you think of a perfect storm, there's all these things that may come together to get somebody to pick up that phone. And so when they pick up that phone, we have to be responsive, and we have to give them options that are available, and that are available within a certain window of time and that match their needs. And if we can do that, then we're doing really well. And I want to start with or add at this point, kind of the things we're doing that the state's supporting that are going really well. The Treat First thing that was mentioned earlier, that's a giant thing. That's a huge benefit to working with people and developing, prioritizing the relationship. That's super important. And then how do we connect them with people that they feel comfortable with? The state's been really good about supporting the CPSW programs, that's peer support, certified peer support, providing CCSS support, which is a really good program. So we've got a lot of really good things going for us. So I wouldn't want to come in here and just say, well, we do have huge problems, especially I think in the rural areas. But when we look at the successes, there's a lot of good things going for us. Now, let me make a couple of things that we're struggling with. I think that loss of coverage after we're coming out of the pandemic, where some people are going to come off of Medicaid, that's going to be a big issue. So we need to figure out how we're going to manage that. That's going to create a real problem. I really am concerned about that. I think this is kind of a thing that there's a curious thing, is commercial insurance, or private insurance, like if you have a commercial Presbyterian plan or something like that, they're not really, they don't have as robust a service. Now, it used to be, well, Medicaid is really limited, and it's got some limitations for the care that we need, years ago. Now it's kind of flipped around. It's like the Medicaid programs provide all these wonderful things like peer support, CCSS work, and other funding. And the commercial and the private insurance, they're not able to cover those things. So we're having a problem where actually the ones that have private insurance are actually not going to get the funding or the services available for clients. So it's kind of sad that that's the case, and but that's kind of the world we live in. So there's a couple of barriers that are a couple of things, some good things and some things we need to that are concerning. And I'm just here to try to work on building things. I've been doing this for 28 years. Recently started an RTC, sober living, medical detox, and other things. And it's been a pleasure, and I look forward to working with people, with MCOs. If Melina's going to come back into the Medicaid area, I'm looking forward to working with them and the innovators that are willing to try to develop new things like sober living. If you get some funding for sober living, that's a big thing we need. And just developing a relationship that really supports the clients as they go through. Retention is such a big thing for clients. If we get clients in, if they go through, like I said, the perfect storm happens, they come in, we get them started. We want to retain them. We want to keep them. So we want to give them what they need. We want to keep them excited and try to do things to make them want to come in. And we're constantly trying to do that. And we're going to need everybody's help in the community to try to create that energy and that excitement about coming into treatment, because it's not fun or sexy when you start it. But once you get into it, we want to keep you. And so that's the challenge. And there's just a couple of quick points, but thanks for giving me a minute to talk.
Thanks, Paulie. I remember, all those days and nights as a police officer, like when you had that moment and you have that person, you've got to have a place to put them. And New Mexico has for a long time suffered from that. I'm ready to go and finding that place that will meet that need. So excited to see where that takes us. I want to come back. You reminded me of something. And so I want to come back to Terry in just a minute. But as a reminder for our participants today, if you have questions for our panelists or things that are coming up, feel free to drop those in the chat. We're going to jump back in and ask our panelists your questions here after I ask a few more that have popped up for me. So by all means, feel free to jump in, drop your question in the chat, and we will get back to you right after we hear from Terry and Jennifer. But Terry, let me come to you really quickly. Pix Health is partnering with Molina, I understand, on some non-clinical solutions and bridging those gaps in care with mental health professionals. What does that look like today? I wasn't aware y'all were doing this, and it sounds pretty cool when they tried to tell me about it. So catch us up.
We are doing that. And yes, though we're non-clinical, we really use science-based and evidence-based program to help improve the mental and social health of the members we work with. We provide companionship and engagement using a combination of technology, which is available 24/7 to the members, and a live peer support model where we provide that companionship over the phone. Both of these methods are encouraging and engaging, and we introduce the positive psychology interventions, which we know is evidence-based to really break that cycle of chronic loneliness. Once that cycle is broken, it really helps the members make that connection with the professionals that they need and the community resources and the health plan resources that are available to them. All of this is really working together to reduce loneliness. We've seen some really excellent results at reducing loneliness. And once that happens, it really helps ease those symptoms and improves their mental health conditions. We also help them seek services and resources within their community. We spend a lot of time talking with them, some health literacy support we give them, helping them manage what resources they have with their health plan and become their partner in navigating the system and the resources that are available to them. All of this really helps that individual get a broader range of support and promotes their overall well-being in between seeing their providers. We get a lot of feedback from the people that we work with that they really find us beneficial in between kind of those professional provider sessions, therapy sessions, so that they can really talk about what they learn, they can practice what they learn, they can get that support. It provides a really good bridge. And sometimes we know that there are gaps and there are long waiting periods. And we've really found that this peer support model has been incredibly effective at helping bridge those gaps and helping support them in between, in addition to having that technology available to them where they can seek those resources. They can, we have interventions within that app that they can participate in whenever they're ready to do so, that we know really helps those negative thought patterns and puts them on a path to better wellness.
That's great. And that's a partnership with Molina in this project, as I understand.
It is. We are partnered with Molina New Mexico and larger other states with Molina as well.
That's great. Well, that takes us back to who's going to help us do all the work as Pat and Terry get everybody into or Paul and Terry get everybody into the programs. Dr. Rober Marquez talked earlier about statistics that talked about a deficit of, what did we hear, like 10,000 healthcare workers in New Mexico over the next few years. Dr. Schneider, I'm going to bring you back in really quickly. I love the idea that 89% of your graduates are planning on sticking around in New Mexico. That's a huge help down the road. What can you tell us about the efforts of the College of Nursing to help catch us up on the front end as well, get folks into the front door and excited about these programs and providing these services to all the folks who need them?
Well, first of all, as you mentioned in your last question to me, we have had a significant increase in students in all of our programs, undergrad as well as graduate programs, 45% increase over the past 5 years. And that increase is set to continue over the next 5 years as well. And so that it hopefully will be a large part in addressing some of the needs of the state. And that'll be for both medical workers, nurses, and nurse practitioners, as well as folks that specialize in behavioral health, like in my program, the psychiatric mental health nurse practitioner program. My program's grown as well. When I started at the program in 2020, we were graduating students every 2 years, and now we are actually graduating students every year. We've expanded who can enter the program. It used to be only for people who already specialized, were already nurse practitioners in another field, like nurse midwives or family nurse practitioners. And now it's open to nurses as well as folks who are going for another specialization in psychiatry. And then I personally, so I'm a transplant to New Mexico. I came from New York originally and moved to New Mexico in 2003 with my husband. And we left in 2008, sadly, and missed it so much that we came back. And everyone tells me, land of entrapment. And so while I'm a transplant, I believe very strongly in how lucky I am to live in New Mexico, how many opportunities this state has given me in my personal and professional life, and to meet the needs for my family. And so I'm just acutely aware of the needs here in New Mexico. And I think part of addressing that shortage is the quality of the training that we provide folks. It's not just about how many we can train, but that we're providing these really high quality training programs, because I believe that New Mexicans, to meet the need that we have here, we really need to have not just as many people as possible, but the highest trained people that we can have.
Thank you, ma'am. And congrats, y'all are doing fabulous work. And I don't think we've told enough of that story yet. So hopefully we can help to do that. I'm going to bring Paul back in really quickly and just say, I get the opportunity I've been a city councilor now for 8 years. I've been the city council president a few times through some really tough challenges, but we're doing some really cool stuff that's getting a lot of new attention nationally about being proactive and doing non-police response to behavioral health and mental health and homelessness and addiction issues. But we can't have a single conversation in the city of Albuquerque about healthcare or community issues without addressing things like fentanyl, because it has become such an overwhelming influence on top of all the challenges that New Mexico had before these idiots created this thing. But it's not just anecdotal, right? Paul, I think, what is the number that we shared earlier? I think the Kaiser Foundation says the drug overdoses in New Mexico obviously far exceed the national average, but majority of those are opioids now. 75% of drug use, I think, over deaths coming from opioids, exaggerated by fentanyl. I mean, you're on the front lines working with people who are in that moment, trying to take those steps. Like, what can we do to intervene here and reverse this trend? Because we don't seem to be making a lot of progress.
Yeah, it's really frustrating. It really knocks the wind out of me. I mean, I've been working with opiate addiction for a long time, and it was tough to treat, 20 years ago, and now with fentanyl, it's just really hard. And the answers are they're fairly clear to me. In terms of what we need to do. We need to have more MAT, medical assisted treatment, out there. We need to have Narcan and reversal kits available, and getting people set up with those and trained in how to use them. which is pretty simple. So, stigma is a big thing, bringing families in and talking to them about how to handle a Narcan reversal kit. It's an important thing that we break the ice on those conversations and talk about it, and get the substance use out of the shadows, get it out in the open where we can talk about it, because in the shadows people die. It's just an incredibly difficult thing to treat. It used to be that we could do some stuff with 12-step programming and counseling, IOP, residential. One of the I don't mean it's too dark, but one of the things that's the kind of the hardest pill to swallow is if you send somebody, maybe that's a bad expression. If you send somebody to 30-day program, in the old days, you think, well, you can help them by sending them to 30 days. And the truth is now, you can help them by sending them to 30 days, but it's about the long-term plan. What are we doing when they get out? The thing of like send them to 30 days and they're going to be better when they get out. For fentanyl, of people that are experiencing fentanyl, the drive is so strong that oftentimes that's not going to have a good outcome. So the old ways of doing things really need to be reconsidered, and think about how we're going to make this where we have good outcomes that are lasting, and we need to really increase our capacity to provide good quality treatment that's readily available, that includes a variety of modalities. So it's not just MAT or reversal kits, but it's everything we can do to help these people stay connected. And like I mentioned earlier, retention is so important. We want to keep them involved, keep them engaged, and just find every way possible to work with them. And it's a huge challenge, and some days are better than others. When we lose somebody or we hear about somebody getting, dying from an overdose, it just really takes the wind out of our sails. But we work together. We're a good community, and we'll keep plugging away here and try to make things better every day we can.
Thanks, Paul. Yeah, I think there is there are some progress being made. It's just a capacity and really finding out all those options and putting them in the right places. And so don't go far, because I want to come back and you can give us advice and tell us exactly what to do as policymakers to fix all these problems. But let me come back and try to bring everybody back together again. Terry, Jennifer, I'm going to come to you in just a moment and sort of do some follow-up. But let's talk about some of these. We've talked about a lot of the challenges. We've talked about opportunity, but says one policymaker to others, like, what should we be doing at the policy level? What can we do at community organization level? What should we be funding better or more appropriately? I think the investment in the College of Nursing, for example, by the state is already showing dividends by increasing graduation from every other year to every year, and in putting more people out that want to stay here. What would you like to see, and what can policymakers do to increase access to healthcare, behavioral health, and substance abuse treatment for all New Mexicans? Terry, you want to jump in there first?
Sure, thank you. I think one of the big things for me is that, again, like I said before, we start seeing loneliness as a chronic condition in its own right, not just a feeling, that social isolation and loneliness are not the same and need to be addressed differently, understanding that loneliness has real physical and mental health effects, and that it changes the way a person's brain works. And I really feel like it should be treated with intentional proven interventions. And it would really help if we could add it as its own specific behavioral health diagnoses. I think that's one of the big things that we can do in the field, is really recognize it as its own unique kind of diagnoses with treatment options, that these feelings of loneliness can be really destructive to individuals and families and our healthcare system. And it really has to be identified and treated as chronic and a very real medical condition. Again, not just a feeling, because we know that if we reduce the loneliness, it has positive effects beyond just mental health. It can really help people manage their medical conditions. It'll help them with med adherence. They usually go to their doctors if they're feeling less lonely and their wellness is better. They are compliant with their physical health regimens as well. And I really believe there should be a billable code for loneliness so that medical practitioners are able to address it. There's codes for all sorts of things. And really, I think loneliness, it would be great to have one. If we were really able to proactively address loneliness, the downstream effect would be amazing on our communities, on our individuals in the healthcare system.
Well, And you mentioned that, Terry. Let me just follow up before I go to Jennifer. This is not my area of expertise, but in prepping for this, I think we learned, like you said, there's codes for almost everything. Like I think somebody referenced, like there is actually a billable code for somebody hit by a duck, right?
Struck by a duck is a code, correct? Isn't that silly? But not loneliness. Yes.
Yeah. So are we getting the right data? Do we really know? I think that's one of the things I heard from the Surgeon General's, I think on NPR this morning. Like we're not really sure except self-reported data, and we're not sure we're capturing everybody to do that. Is that a good first step for increasing that, or do we capture the right data?
I think that's a great first step. And again, I think one of the things we're trying to do here at Pix Health is help people identify that they are lonely, right? So within our app, we do some screenings, and so really helping them identify that. And I think if it were a diagnosis that your medical professionals would be more likely to ask you about it, because they would know, right? They could diagnose, they could treat, there would be available treatment interventions. And so if we had a diagnosis, I really think that is a good way to destigmatize, to expand the treatment that's available, to recognize it as a chronic and treatable mental and physical health condition.
Jennifer, let me segue to you. So practitioners at your level, what do policymakers need to do to do better? And what do you think of Terry's ideas, and how, what else can we do to layer on top of some of those?
Yeah, I think what Terry says makes a lot of sense. And I think it would be great if we had a code for loneliness. I think that some of these things do go unrecognized when they're not something that's billed for. And so it's not something that's noted necessarily officially as part of a visit. For us, one of my biggest challenges is always finding clinical placements for my students. We're limited in that because, because we have so many shortages of so much of a shortage of behavioral health providers. That means then we have a shortage of people who can provide that training to students to help them to finish their degrees and get the clinical experience that we need. So certainly anything that can be done at the state level to really support agencies, individual clinicians to be mental health preceptors for their specialization across the fields of behavioral health care would be enormously helpful in educating more providers in this state. Some of the ways that can be done is through tax incentives for individuals who are clinical preceptors, for sites. In some states, sites actually are paid to provide clinical support to students. And all of that would really just help address this shortage.
That's great. Yeah, and I think the more the merrier, right? There are lots of solutions and lots of gaps to fill. Paul, keeping that trend about loneliness going for a minute, to come back to Terry's point, I mean, one of the things we all know from anecdotally or from personal experiences, and you mentioned, people with strong support networks are more likely to get into intervention earlier, get into support services earlier, and to remain an active participant. What can we do to help people create those systems better, or what's the impact? What are we missing there?
Well, community is really, I think, one of the biggest things that we do for an answer to that. How do we create community? What do we do with that? I mean, the whole concept of people that are receiving treatment, that they do better in a group setting than they do in individuals. Well, why is that? Well, they common goals, shared experiences, and it breaks that loneliness. I mean, that sense of isolation and feeling inadequate and shame and guilt, all that stuff is just a horrible burden to carry. And how do you how do you break shame down? How do you break loneliness down? Well, it's through interactions. It's through interactions and feeling like, I'm feeling really terrible about myself, but I'm feeling pretty terrible about myself with a bunch of other people that feel that way too. So it creates a bond. And then how do you get self-esteem? You don't get self-esteem by, this is an overgeneralization, but self-esteem doesn't generally come by just me saying, oh, you're good, you're a great person. If you've got a very deep well of shame, that doesn't just go away by somebody patting you on the back. But it goes away by being connected with people, and you start to normalize your experience, and you start to feel like you're not alone. And there's a lot of ways we do that. I mean, the old, 12-step stuff, a big part of that is community. We're trying to find every way we can. The CPSWs that are out there, they break some of those barriers down and help people feel not alone and take that shame. We want to flip that shame on its head. We want to go from being ashamed of things to from addiction, and if you keep repeating the same thing, the shame just kind of reinforces itself because you keep, if you're doing things that you don't feel good about that are not incongruent with your values, you're going to continue to feel badly about yourself. And the way to turn that around is to find ways where you start to feel like understanding where addiction plays a role in your life and why you did those things, and it's not because you're a bad person. And then get that shame in a place where, okay, well, in my history, I've done some bad things, but today I'm not necessarily proud of being, and if we aren't too offended by labels here, I'm not ashamed of being an alcoholic. I'm not proud of being an alcoholic or an addict, but I'm proud of how I deal with it. I'm proud of how I am recovering. What am I doing in recovery? How do I feel good about myself in recovery? And that sense of like feeling self-esteem around how I deal with it is super important to reinforce, and it happens in community. It doesn't happen the same way in an isolation space. So we find every way we can. We've got a whole center around getting people in, whether it's recreational things or yoga, volleyball, nutrition. All that stuff involves community. We want everybody to be part of a community and feel like they belong and there's common ground. And when you do that, you see people, they just start to develop and grow and blossom, and they start to shed the old shame vibe, and they start to move into a place of, I feel good. I look better. I feel better. I'm doing better. I'm more responsible. I'm in tune with my values. And when you get in tune with your values, then you start to feel better about yourself. So that's the community piece. And I think the loneliness piece is a great point. So really, really well said, everybody, on the loneliness piece.
Bringing these threads together is really important, and I really appreciate all three of you for helping us to do that. Let me get to, I realize we've all sat through lots of meetings. I know that the most hated person is always the one who hosts the meeting right before lunch or right before 5 o'clock, and I'm not going to be that guy. So we're going to respect everybody's time. But I do see a couple of questions and I really want to jump in. Jennifer, I'll ask you to speak for all of UNM for the School of Medicine, but is UNM still participating in school-based health centers to address student mental health and behavioral health issues? And is that still a part of the outreach and programs that the school's doing?
Yes, absolutely. There's still a robust school-based health centers, and there are a variety of learners at those sites, as well as nurse practitioners and physicians.
That's great. And I think that's a great follow-up. And I also want to acknowledge and say thank you to Mary Stefanovic, who in the chat mentioned this long-term social or health status study that's happening with COVID patients through the epidemiology unit. They're finding some really great data on sort of long-term social impacts and behavioral health impacts. And they reached out asking for some options, maybe Carolyn, to help connect with Molina to see if there are opportunities to do that work. So we're going to make that connection here after the event today and hope that that somebody can start that conversation. So I want to say thank you to all of you for being here. As a policymaker, I don't get to sit in the room with the patients. I don't get to get out on the street with the folks. We get to put all this together and try to figure out where to put resources and how to partner with people doing good work. And everybody here that's participating with us today is seeing folks that are doing exactly that. And I want to say thank you to everybody for giving up your time today to come teach us a little more. Carolyn, you've got a lot of work. Your team has got a lot of work to do, but the foundation and Molina have been a great partner in New Mexico with all of these folks. Can I throw it back to you for a few closing remarks before we let everybody go to lunch today?
Thank you, Pat. Thank you for hosting for us today. And I want to thank Secretary Armijo and Paul, Jennifer, Terry, Dr. Roban Marcus, everybody for putting this discussion together. And even if you didn't get to ask your question today, feel free to send us an email. We'll make sure to connect you back with the folks that are on the discussion. And one of our goals that we implement across the country with the Molina Cares Accord is to make sure that we're sharing learnings and sharing information and collaborating and bringing communities together to do that. So that's one of our goals with this panel and the presentation Really want to thank everybody for participating. If you want to find out more about what the foundation is doing, feel free to visit our website at molinacares.com, and I'm happy to share information there as well as molinacares.org. So thank you so much, everyone. Have a great afternoon. Thanks for joining today.